This conference will now be recorded.
Okay, all right. So on Friday, we've been talking about electrical activity in the heart and how we have this sort of hardwired system designed to prevent us from having out of sync or out of rhythm contractions. Right? And it would be wonderful if that was really as foolproof as it would sound, but in fact, it often is not. It's very, very easy, in fact, to get slightly out of syncopation rhythms, rhythms that are too fast or too slow, any of these sorts of things. And generally speaking, we kind of collectively throw these things in the arrhythmia category. Right? Anything that is out of the ordinary. Again, this can be extraordinarily rapid, can be extraordinarily slow. But more typically, what we've got is a slightly out of sync atrial and ventricular contraction. That's typically what we are concerned with arrhythmias. And the biggest worry that we have with an arrhythmia, even if you walk in under your own power, is that it can very quickly lead to fibrillation, which is a condition where the beat is so rapid that we actually get overlap, temporal overlap, between atrial and ventricular contraction. When that happens, no blood gets pumped. Okay? And if that persists, obviously, to the point where no blood is being pumped, then you die. One of the things that you'll see on TV a lot if you watch, I recommend against doing this, but if you watch a lot of medical dramas on TV, invariably once a week or so, you will see someone on a table and they'll bring the paddles out, the clear and zap the person, and very, very dramatic sort of thing. In reality, a defibrillator, which is what those devices are called, are really in use only for this sort of thing. And what they do, and the reason you have to not have your damn hands on the body when somebody else is doing this, is that you place one paddle at the apex of the heart, you place one paddle at the base of the heart, and it shoots a relatively powerful electrical current from base to apex, simulating the normal pathway of flow of electricity through the heart. And the idea there is that that large amount of current overrides the arrhythmic signal and resets you on a normal rhythm. Works pretty well most of the time. I wouldn't say it's foolproof. I wouldn't say it's perfect, but it does a pretty good job at what it does. If you have node-related issues, so your autorhythmic centers are out of whack, one of these is okay. One of them is extremely not okay. So if you have a defective sinoatrial node, we have typically what we get what's called ectopic focus. You will see the term ectopic thrown around, particularly as you get deeper into pathology. Ectopic simply means something that's not where it's supposed to be. Right? So we talk about, say, ectopic pregnancies, right, where we have implantation in the uterine tube rather than in the uterus, okay, stuff like that. Here, ectopic focus simply means that the focus, the base rhythm generating region of the heart, is not where it's supposed to be. It's not at the SA node. Where the rhythm or the focus is then, right, is at the AV node, right? And if you remember, the AV node and its junctional rhythm is a little bit slower than we see with the sinus rhythm, right? About maybe 50 beats per minute, somewhere in that neighborhood. And 50 beats per minute isn't going to necessarily kill you, but it ain't ideal. Put it that way. It's really going to put a damper on your marathon running days. Let's say that. Another place where we can get ectopic focus is not necessarily from a defective SA node, but when we've got some kind of mitigating factor here, some sort of adulterating factor, setting the sinus rhythm too high. Okay, and so there are, of course, any number of recreational drugs that will do this. Probably the most significant, presumably the most significant for you guys. I don't want to make any guesses about what you do with your spare time. But caffeine is a big one. Nicotine will do those things. If you ever had too many cups of coffee or one too many cigarettes, although allow me to be preachy and say that one is one too many, you often feel jittery. And you kind of feel unhappy, maybe a little fluttery in the chest. This is an ectopic focus, right? Because of that stimulant activity. Okay, and again, there are a number of other stimulants that will do this also. Setting that rhythm abnormally high. Now, typically that's not going to kill you, right? Either you'll just be really unhappy until the drug wears out of your system and you're good to go again. Now, if on the other hand your AV node doesn't work, that's bad. That's real bad. A defective AV node typically gives us what we call heart block. And if you remember what the job of the AV node is to do under normal conditions, right? It's primarily there to give us a bridge between the endocardial conducting network and the SA node, right? It's that little pause that we build in to make sure that we have correct syncopation between the two contractions. If the AV node is faulty, we get what's called heart block. That signal is not passed to the ventricles, or if it is passed, it is extremely weak. Okay? And if there is no signal passed to the ventricles, they don't contract. If your ventricles don't contract, you die. So if you've ever known somebody with a pacemaker, this is what those are installed to solve. They are there to help. They basically translate the electrical signal from the atrial systole, from the SA node, kind of bridging that faulty AV node there and send it off to the ventricles. If you go on and do anything in terms of grad school, you are going to do cadaver dissections. Odds are pretty good that one or two people in that room every year are going to have a pacemaker in. If you have a living patient with a pacemaker, the same thing, I guess you reply, they are extraordinarily dangerous to handle. Okay, you do want to be aware, again, this is where charting and history becomes important. You do want to know if a patient has one, because you do have to make some extra precautions in that case. All right. Now, the last thing here in terms of electrical activity, coming back, going to the heart, I guess, is again, remember, right, we have this sinus rhythm. We don't need any output or input from the nervous system at all, okay, to continue living, at least at a relatively sedate pace of life. However, we do have means of modulating that resting heart rate through the autonomic nervous system. Sympathetic nervous system is going to artificially speed it up. Parasympathetic nervous system will bring us back down to resting and will drop us below resting. We can't go below sinus rhythm, okay? But we can bring back down to resting. And again, if you think about some of the things that we talked about, the end of AMP1, right? We had talked about these cardiovascular centers in the medulla. I can find my cursor again. Where did it go? There we go. Right? And of course, within there, we have that are considered part of the sympathetic nervous system and some that are part of the parasympathetic nervous system. Cardio-acceleratory, right, of course, tells us that we're speeding up. Okay, so sympathetic. Cardio-inhibitory center, of course, that's the opposite. And so we do, of course, have some connectivity here. Both of the nodes, both SA and AV nodes, are connected to both the sympathetic and parasympathetic nervous system. The sympathetic nervous system also has connections with the ventricular muscle. So not only can the sympathetic nervous system control rate of contraction, but also force of contraction, and also increase the force of ventricular systole, pumping more blood, or at least more blood under pressure. Now, one thing that you are probably very familiar with seeing, maybe not necessarily reading, but certainly seeing, um, are the electrocardiogram traces of electrical activity in the heart. These are EKGs or ECGs. I'm old, okay, and so we used EKG when I came up for cardiogram, but in German. It's otherwise spelled exactly the same. It's just that cardio in German is a K, not a C. More commonly now, stateside, you will see ECG, again for electrocardiogram, but spelled in the English way. And the idea here is simply that we are going to have a means of monitoring the depolarization and repolarization of the heart muscle as it moves through the cardiac cycle. Okay. Now, you will have classes, I have no doubt, where you will learn a great deal about how the ECG works. Here, for right now, we're going to break the ECG down in just three chunks. Okay. The P wave, the QRS complex, and the T wave. Now, within that QRS complex, there's a lot of things going on. And again, you will probably learn more about that than you ever wanted to. We're going to keep it here just as this one complex because it's really one waveform and it's hard to kind of separate out things that go into it. So let's take a look here at an ECG trace of one cardiac cycle and talk a little bit about what's happening with each of these parts. So here at the P wave, this tiny little blip here, it's not a big one, of electrical activity. This is atrial depolarization. So this is the SA node, okay, firing off. It's not a lot of electricity, right? Not a lot of muscle in the atria, okay, but it is there. Then we're going to get into, after this little interval here, we have the QRS complex. And what's happening here are two things that kind of overlap significantly that are both electrical events. We have the repolarization of the atria, because we depolarize, then repolarize. And we also have the depolarization of the ventricles. And so in here, right, the biggest part of this that's going to be kind of noticeable in here is the R part of the QRS complex. And again, that's going to be primarily ventricular depolarization. A lot of muscle, a lot of electricity. It's swapping out a lot of what we see here. We see kind of this little dip here at Q. This is repolarization a little bit, but primarily what we're seeing in here is that. So those two things kind of overlapping in the middle there. And then again, we have another little pause, and we have the T wave at the end, and that is going to be the repolarization phase of the ventricle. So if you look at heart activity, as sort of related to what's exactly going on here, the SA node here triggers our P wave. As that signal propagates, we have a little pause in activity, right? As we reach the AV node, right? That's our 1/10 of a second, sitting right in there. Okay. Repolarization, depolarization brings us to the QRS complex, QRS. Okay. And then we eventually get to repolarization of the ventricles, which brings us to our T wave. Now, prior to having an ECG device, which is really not that long ago, and honestly, even today we do this for, typically for physical things like that. The way that we got our best picture of internal heart activity was through a stethoscope, right? And we're listening for heart sounds. And if you have a doctor worth his or her salt, they will, of course, move that stethoscope to 4 locations around your heart. And the reason that we're going to do that is because we're going to be listening for sounds from each of the 4 valves. Okay. And recall that there are 2 AV valves and 2 semilunar valves, and we want to have a sound from each of those because what we're listening for is the flow of blood through them. And anything abnormal in terms of the sound that we hear, it's going to indicate either a stenotic or an incompetent valve in that location. So again, when we think about heart sounds, right, it's this lubbed up, lubbed up, lubbed up kind of sound that we're hearing. What the actual sound that you're picking up through the stethoscope is the valves closing. Right? You're hearing them slam shut. Right? So we have a closure, right, of the AV valves closing. As the ventricles contract, slam the AV valve shut, and the ventricles relax, and blood flows, tries to flow back into the heart, right, and slams the semilunar valve shut. That's what those sounds actually are. An abnormal sound, we typically refer to these as murmurs or a heart murmur. And again, this is telling us, depending on the sound, whether we're dealing with a stenotic, an overly stiff valve, right, or a incompetent valve. So what we're going to be doing here, right, is again, we're going to be moving around the chest, hearing these sounds. We have two of these sounds just to the right of the sternum. So we have one here at the second intercostal space, okay, roughly where the base of the heart sits. And here we are closest to the aortic valve. So the sound of the aortic valve will be strongest here. We're then going to move down to the fifth intercostal space. Here, again, just on the right side of the sternum. Here we'll be listening for the tricuspid valve. And then on the left side of the sternum, we have, again, at the second intercostal space, the pulmonary valve sound. And then here at the apical impulse, right, just below the fifth intercostal space, typically, we have the mitral valve sound. So again, you will hear a murmur typically in all four of these locations. What we're doing here is we're seeing where it is loudest. Okay, and that's going to indicate which of those valves we are concerned with. We can additionally look at the cardiac cycle here as a mechanical event, right? So in terms of not electricity, not in terms of blood flow necessarily, which is kind of what we're getting at with heart sounds. We can look at it in terms of what is the muscle itself doing. Right? And this is where the terms systole and diastole come into play for us. Right? Systole here being contraction, diastole being a relaxation. And so we can talk about atrial systole and atrial diastole and ventricular systole and ventricular diastole as they independently move through their contraction and relaxation cycle. As part and parcel with these series of contractions and relaxations, we're also going to be able to monitor changes in blood pressure, both within and outside of the heart as we go through each of those parts of the cycle. So what we're going to do here is kind of go stage by stage through, we're going to kind of consider to be one complete cardiac cycle here. And the place that we're going to begin, not for any particular reason, this is not necessarily set in stone, begin here, it's just where we're going to begin, with the stage here of ventricular filling. This is in the middle to late stages of ventricular diastole. So as the ventricles relax, as they kind of reset from their contraction, we begin to fill them with blood from the atria. Obviously, the AV valves themselves are open. There is atrial systole associated with this. However, because again, remember those walls are so thin, there's so little muscle associated with them, that generally speaking, when blood enters the ventricle, it's under essentially no pressure. Most of the blood is going to flow in here essentially passively under the influence of gravity primarily, some elastic rebound from the atria themselves. Generally speaking, not a lot of pressure here. We're going to concern ourselves in terms of monitoring heart efficiency here with something we're going to call end diastolic volume or EDV. And the end diastolic volume is simply what it sounds like. It's the amount of blood in the heart, or the ventricle, at the end of diastole. So as the ventricle is as full as it's going to be, we have a certain volume of blood in there. That's what the EDV is all about. The next stage, as you probably can guess, is then ventricular systole. So we're going to contract the ventricles. This is going to close the AV valves and open the semilunar valves. So this is where we'll hear our first heart sound, right? The closing of those semilunar valves. We're going to force most, although not all, of the blood up and out of the ventricle. And we're going to be left with some remainder at the end. Right? It's called the end systolic volume. So during contraction, during systole, we squeeze, again, most, but not everything out. There is some left behind. And then the third and final stage here, call this isovolumetric relaxation. The phase here is where everything is more or less in diastole simultaneously. The atria are relaxed, blood is filling them. The ventricles begin to relax. They're not quite beginning to fill yet. The atria are filling first. And what we're going to see here notably is when we look at pressure here, we look at systemic blood pressure, there's a tiny little blip in blood pressure called the dicrotic notch. And as you learn about blood pressure and you sort of get into the clinical aspects of it, that dicrotic notch becomes an important little landmark for you. All that is a tiny little blip in blood pressure, that kind of an upward thing, caused by the rebound of blood against the semilunar valve, against the aortic valve. So blood is being forced up and out, and then it slams back against the valve during diastole. It slams back against it diastole, and a little pressure width that goes through there, called the dicrotic notch. It's not huge, but it is there. And then we begin all over again with phase one here, ventricular filling. Now, obviously, you could start at any one of these phases if you wanted to start at that particular phase. It doesn't matter. As long as you get through all three parts of it, you end up at the same place anyway. Okay. So if we look at all of these things together, which is really kind of a valuable thing to do, and I would encourage you strongly to do this and to study this sort of thing. We can tie in our ECG, right? Our P, QRS, T, our heart sounds, right? Our AV valve closing, our semilunar valve closing. We can look, we haven't really spent a huge amount of time with this yet, but volumetric pressure. And we'll spend a little more time with pressure in a little bit. There's the dicrotic notch here. And then with your atrial and ventricular activity, atrial systole here, ventricular systole there, and then volumes of blood in the ventricle. So the EDV is the most amount of blood that will be in there. The ESV is the least amount of blood that will ever be in there. And then we'll talk a little bit here about stroke volume, which is just going to be the difference between those two. Then, of course, you can also look at this in terms of where blood flow in the heart is at any given moment in time. So I would, like I said, I would really, really strongly encourage you to try to not just understand what each of these little parts are in isolation, but also what they mean in the other aspects of the cardiac cycle that we've talked about. From a physiological perspective, what we're primarily concerned with, or we primarily think about, is what's called cardiac output. Cardiac output is basically how much blood does each ventricle pump in one minute. Okay. So if you want to get total volume of blood pumped, you'd have to double cardiac output, because that's two ventricles. But one ventricle is this cardiac output. And it's really, really quite simple to calculate. We need to know heart rate, right? The number of beats per minute. And then we need to know how much blood gets pumped each beat, right? We'll call stroke volume. Again, remember, stroke volume, really, really easy to calculate. It's just end diastolic volume minus end systolic volume. It's this. It's this little part right there. So we know those two things. We can multiply them out. We can get the amount of blood pumped by a ventricle in that 1 minute of time. Now, for the average person, we're looking here at about 5¼ liters per minute, or roughly the volume of your blood every minute. Somewhere in the neighborhood of 5 liters in your body, pump a little more than 5 liters every minute. Pretty close. So what this means, how we arrive at this number for the average person, is that we have an average resting heart rate of about 75 beats per minute. Remember, that is our typical sinus rhythm. And we have a stroke volume of about 70 mils. So we end up with 5¼ liters per minute. Obviously, if your heart rate is lower than that at rest, mine, I think, last time I went in January was 63, I think, which is a little high for me, but a little bit lower. Again, anywhere from 60 to 100 is totally normal. That's going to alter your cardiac output a little bit one way or the other. And obviously, if you increase stroke volume or decrease stroke volume, it'll do the same thing. So any increase to either heart rate or stroke volume increases output. Any decrease to either stroke volume or heart rate decreases cardiac output. In terms of sports medicine or training kinds of behaviors, kinesiology, one of the things that we look at here is what is your maximal cardiac output. Right? How far above resting can you go? And for the average person, it's about 4 to 5 times your resting cardiac output. So, maybe you're looking at 24 to maybe 30 liters per minute. Just pretty big increase, right? But when you compare it to, say, professional athletes, right, we're looking at maybe 35 liters per minute. Right? So again, a significant increase above the average person. And another measure of this kind of ability here is what we call the cardiac reserve, which is really just what's your maximal cardiac output minus your resting cardiac output. Again, what's your ability for expansibility for athletic endeavor. Now, we've talked already about how we manipulate heart rate. Right? We've got an input from autonomic nervous system, brings us up, brings us back down, whatever. Stroke volume is a little bit trickier to manipulate, and so we don't really see huge variations in this within an individual typically, although it is possible to do so. One of the things that's going to affect that stroke volume is what we call afterload. So recall that your circulatory system is closed, right? There is blood in every artery, every capillary, every vein at all moments in time, okay? And so in order to move blood through it, you have to push the blood in front of you out of the way. So it's a bit like if we had a fire alarm go off in the building, and I stood in front of the door and I just stood there. If you wanted to get out of the room, you'd have to push me out of the way. And if there were 2 or 3 of me in the way, then you'd have to push even harder. Right? That's what afterload is. It's just the pressure that has to be overcome, right? The inertia, basically, of the blood sitting on the other side of that valve that we have to move out of the way in order to occupy that space. So the primary means of controlling afterload is through controlling blood pressure, at least local blood pressure. So higher the blood pressure is, the more afterload there is, the harder it is to move blood through it. So things like hypertension are problematic in terms of cardiac output. They're really going to severely reduce cardiac output. Obviously, of course, heart rate, right? We talk about sympathetic, parasympathetic inputs here. Another way to think about them is what we call chronotropic factors or time-altering factors. Obviously, there are some that are positive and some that are negative. Just real briefly here, because we already talked about this in AMP1, but the neurotransmitters here in play are going to have slightly abnormal effects when you compare it to the rest of the body. So In most systems in the body, norepinephrine is a inhibitory neurotransmitter. Here in the heart, norepinephrine is actually stimulatory. Norepinephrine increases resting heart rate. And I'm not going to be super worried about all of this stuff. Just remember the norepinephrine part and we're happy. By the same token, right, in most of the body, acetylcholine is a stimulatory neurotransmitter. But here in the heart, acetylcholine is inhibitory. So the parasympathetic nervous system will release acetylcholine and will lower resting heart rate. Now, at the, if you recall, the end of last semester, we kind of looked a little bit at some of the major architecture of the autonomic nervous system. And with the parasympathetic nervous system, the biggest component of it, the one that wires all of your internal organs more or less to the parasympathetic nervous system, was the vagus nerve. And so one thing we'll talk about is vagal tone. Okay, vagal tone is expressed in many places, but also here in the heart, right, as resting heart rate. It is under essentially the sort of giving us a floor for what resting heart rate is. Right? Where parasympathetic influence is dominant rather than, say, sympathetic tone. There is one additional little kind of fun thing in here, Bainbridge reflex. Sometimes now we call it the atrial reflex. I don't recall why. I don't know if there was some controversy with Bainbridge or not. I don't remember, but not terribly important. But what it is basically a reflex that prevents overfilling of the heart. Okay, so as the atria swell, as blood enters the atria, they kind of get expanded out. There's going to come a point at which they're going to stretch. Okay, this is normally part of what they do, but a certain amount of stretch is going to trigger a contraction. So we can actually begin our cardiac cycle early due to overfilling. Where this actually comes into play for us is not so much a safety factor, but really more about increasing heart rate in response to increasing venous return. So as we start to be more active, okay, one of the things we'll learn about how the venous return system works is that it's under low internal pressure, and so almost all of it is down to skeletal muscle activity or respiratory activity to move blood back. So as you become more active, you bring more blood back to the heart at a greater rate that way. That's going to be our trigger here for this Bainbridge reflex to increase cardiac output, because again, we're starting to become out of our resting state, and we're going to need a little bit more cardiac output to make that work. If you really, really want to, you can go through, there is this flow chart in the Mary Abed Hone book. I'm not going to go through it, but if this is the sort of thing that really does interest you, there is a little more information in your book about it. There is some hormonal regulation of heart rate, not a ton, I would say. Your heart is an endocrine organ, but it doesn't have its own influence on itself. Here, when we think about hormones, we think primarily about epinephrine, at least in the adult body. Epinephrine coming from the adrenal gland, the adrenal medulla, and it's going to have basically the same effect as norepinephrine. It's going to be stimulatory. During growth, particularly during childhood growth, prepubescent childhood growth, where the thyroid gland plays a major role in in growth, right? Thyroxine, thyroid hormone, this is just another name for thyroxine, also kind of has this same stimulatory role. Again, as we are building, as we're growing, we have a need for a greater metabolic rate to grow faster. That's going to require more nutrients. It's going to require more blood flow. Okay, so thyroxine here naturally then is going to have that kind of stimulatory effect on the heart to match blood flow to demand in the body. Now, one thing that is worth kind of considering here is that as we start monkeying with heart rate, particularly as you start monkeying with it in a positive direction, We start increasing heart rate. It's the same thing that we can perhaps encounter in any muscle as we start overworking it, right? One of the things we talked about with skeletal muscle was the idea that we could reach fatigue, right? Where the imbalance of ions prevented us basically from having a normal contraction. Right? If we don't have sodium in the right spot, we don't have calcium in the right spot, we don't have potassium in the right spot, it's not going to work. The same thing is going to be true here with your heart. And in particular, here when we worry about your heart, we're worried about, again, calcium, right? As kind of one of our big ions of concern. But rather than sodium, we're really more concerned with potassium. And any imbalance in either of those two is potentially quite problematic for us. So thinking first about calcium imbalances, right? We can either have too much, that could be hypercalcemic, we can have too little, it can be hypocalcemic. And again, both not great. Hypocalcemia is going to decrease heart rate. Okay, so it's going to bring us down pretty low, even maybe below resting. Hypercalcemia is going to do the opposite. It's going to increase heart rate. Hypercalcemia, of course, has other knock-on effects. We have kidney issues with that, handful of other things that are unpleasant that goes with that. For potassium, here we're going to have hyper and hypokalemia. So if you ever wondered why potassium is K in the periodic table, kalamus is the Greek word for potassium. So hyper and hypokalemia. Hyperkalemia, real bad. It can quickly lead to heart block, right, which is basically going to stop your heart, cardiac arrest. Okay, so that can be lethal in relatively short order. On the other hand, hypokalemia, not having enough potassium in the right places, will lead to arrhythmias, which again can be not great, can be ultimately fatal. Typically, we're going to see kind of a reedy pulse, right, or a feeble pulse with that, a weak heartbeat based on the lack of potassium. Other big things here that are going to be influential on heart rate is size, maybe really more than age. One thing that you'll find as you start studying animals in general is that the smaller the animal, the faster the heart rate. So if you go home, you have a dog or a cat at home, particularly if you have a cat or a small dog, their heart rate is going to be seemingly astronomical. It's going to be in the hundreds. Right? A house cat can have a heart rate, a resting heart rate in the 120s and not break a sweat. Similarly with people, the smaller and the younger they are, the faster their heart rate is going to be. If you have a kid at home, right, and they're relatively young, their heart's again going to be in the hundreds without really being problematic. And this has everything to do with metabolic rate and trying to generate enough internal body heat to compensate for the loss of heat to the outside world. As you get bigger, you get more mass, your surface area proportion gets smaller, you can have less of a problem with that, your heart rate goes down. Similarly, this should really say sex and not gender. Typically, female heart rates are faster than male heart rates. Again, this is one of those size-related things. It's not really anything else. Women tend to be smaller than men, and so they tend to have faster heart rates. That's really all it is. Not anything other than that of any real importance. And of course, these last two, exercise and body temperature, are linked. A higher body temperature or a increased amount of exercise will both jack your heart rate up. Where heart rate goes wrong, right? Again, anything that's abnormal, so outside that 60 to 100 beats per minute for the adult range, is where we start to maybe consider intervention. Tachycardia is an abnormally fast heart rate, anything above 100 beats per minute. And these can be driven by any number of different things. You can have tachycardia because you're dehydrated. It's actually really common in people your age because you don't drink enough water, you drink too much damn coffee. I'm guilty of it too. But it can often lead to tachycardia. It can also be any number of different pathologies. Typically, when a person is walking into a clinic under their own power, we're not overly concerned with it leading to fibrillation at that point. We are more concerned with it as a complication of other things that someone has come in for. But we do still want to monitor. The other version of this bradycardia is only a concern if the person is experiencing discomfort. A really highly trained athlete, for example, can often easily have a resting heart rate below 60, and it can be perfectly normal. In fact, having a resting heart rate below 60 in the absence of other complications is usually a sign of really good health. It's not necessarily a bad thing. We really only worry about it if it's leading to things like anoxia or other sort of problematic conditions that go with it. Something that you will see a lot in the modern world here is congestive heart failure. Congestive heart failure is a what we call a progressive disease, in that you can kind of encounter it in multiple stages. It gets worse through time, I guess is the best way to describe it. And basically what it is where you have one side of the heart that can't keep up its end of the bargain. And because you have one side that's not keeping up its side of the bargain, what ends up happening is blood backs up, and afterload for the healthy side of the heart becomes extraordinarily high, and it actually ends up weakening the healthy side of the heart too. So this is what we mean by progressive. It starts on one side, it's bad, and then it weakens the other side too, and eventually we get to the point where your heart really doesn't function very well at all. Root causes of this, atherosclerosis is a big one, so blockages of major arteries leaving the heart. Hypertension, high blood pressure, again, because we're increasing afterload. Multiple heart attacks, okay, which lead to increased fibrosis of the heart muscle or weakened heart muscle. Things like that. So like I said, it's going to be one side or the other to start us off. So we can talk about pulmonary congestive or peripheral congestive heart failure. Again, dependent on whether we're dealing with the right side or the left side of the heart. For pulmonary congestion, the left side fails. So it's not maybe what you thought. But we refer to congestion here as where the blood actually pools. So if the left side fails, right, we can't move blood through the left side. So blood backs up one stage before the heart, which is, of course, in the lungs. And so we get pulmonary congestion from that. For peripheral congestions, the opposite, the right side fails. And so we can't get blood into the right side of the heart. So blood pools in the bottom. So we get edemas in your viscera, so it tends to swell your internal organs up. And again, this is a situation where it's not going to move forward in a positive way. So treatment-wise, we try to lower blood pressure off the bat. Sometimes we can drain fluid, particularly if we have peripheral congestion. We drain edemas that way. There are a handful of drugs that will try to increase cardiac motility, but those are a little dangerous, a little scary. Not a good thing to have, I guess. Take home on that. So if you can prevent it, that's the way to do it. We'll close off here just with a little bit of development of the heart. Again, as we mentioned before, the heart in the adult has this kind of unique naming topography where the base is at the top and the apex is at the bottom. The reason for that has to do with the formation of the heart from these sort of paired muscular tubes and the kind of the folding and twisting that we get out of that. In the embryo, we're going to start anyway with a sinus venosus, which is actually going to retain as the coronary sinus, a single atrium, single ventricle, and so then we'll call the bulbus cordis. And basically what it comes down to is this kind of progression where we start here early on with these two muscular arteries, okay, that eventually fuse. Okay? So we end up with a single artery or single atrium and a single ventricle. And eventually we get this kind of twisting, right, where the ventricle goes from being on the top to being pushed underneath. The atrium gets pushed up to the top. And we end up with the twisting eventually giving us kind of the orientation we expect to find a tailor. We're not going to go too far into that. I think I put it up here because I think it's cool. If you take Dev, I think you're going to have to take Dev. You'll learn a lot more about this in there because it is a very in-depth process. But for here, we're going to kind of just leave it at that. Recall, of course, that there are two connections between the pulmonary and systemic circuits in the embryo. Okay. We've talked about one of these already, right? The foramen ovale connecting the atria. There is, of course, also another one outside of the heart that connects the pulmonary trunk and the aorta. This is the ductus arteriosus. And just like we have a scar on the foramen ovale, on the interatrial septum, here we have a remnant of this ductus arteriosus. This is the ligamentum arteriosum. And basically all that does is it holds the aorta and the pulmonary trunk together. It keeps them from separating. And in theory, these close near birth or shortly thereafter. When it doesn't happen, though, we have what we call congenital heart defects. These are really common, shockingly common. If you work OBGYN or PEDS, you'll see a ton of these. Okay? In any reasonably sized city, you'll see a ton of these. And basically all that's happening here is we've got an incomplete separation of our two circuits. And so we have a diminished oxygen transport capacity. That's really mostly what it is. There are other versions of this where we get what are called coarctions or sort of constrictions of some of these vessels. If you have both of these types of defects, you have both a coarction and a incomplete closure, you have what's called the tetralogy of Fallot. So looking just at a couple of these, rather all of them, but a couple of them. Septal defects are really common. 1 in every 500 or so live births, you'll see a septal defect. The one we've got illustrated here is a ventricular septal defect, but there are, of course, also atrial septal defects. And again, this is just a mixing of blood from the two different pathways within the heart. Here we have instead an example of a coarction, right, where you see the aorta coming up, and you can see here it's relatively large all the way through, but there's this little constriction or coarction or arctation here, okay, and narrowing. And that, again, not uncommon, but 1 in every 1,500 births, live births, you'll have a coarction of some description. And then 1 in every 2,000 births, we'll have both. So this is an example of a tetralogy of Fallot, where we have both a coarction and a septal defect. Then finally, getting old sucks. Again, we say this every chapter. It's always true. The older you get, the more likely you are to experience things like stenotic valves. The valves themselves get thicker and they're less flexible as a result. You lose some capacity for contraction, and so you'll see a decline in cardiac output. You'll see a decline in maximal cardiac output. Atherosclerosis is a progressive thing where it builds up over time, so it becomes more common in older people. And so older people are, of course, more prone then to essentially all of the various heart defects and heart pathologies that we've gone over to this point. They can occur in people your age. They do. People your age have heart attacks all the time. Okay. Don't think it can't happen to you, because it can. But it is certainly more common, more prevalent in older people. And so if you work with older populations, with geriatrics, for example, cardiovascular disorders are really kind of the top of the line in terms of what your concerns are. Okay. All right. I will see you guys in class tomorrow for exam. You guys have a lab exam tomorrow, or are you guys Thursday? You guys are Thursday. Okay. I have one section that's tomorrow. I have one section that's Thursday. We'll see you in class on Wednesday. I'll tell you more about how the exam's going to work then.